Shock in the newborn is defined as a state of inadequate circulatory volume or function that prevents sufficient tissue perfusion and oxygen delivery. As perfusion falls, anaerobic metabolism predominates, leading to lactic acidosis and progression toward cardiovascular collapse. Early in the course, compensatory mechanisms such as tachycardia and peripheral vasoconstriction maintain blood pressure despite impaired organ flow. This stage, often called compensated shock, can be clinically deceptive as systemic arterial pressure remains within normal limits. If untreated, myocardial dysfunction and impaired vascular regulation progress to uncompensated shock, where hypotension emerges as a late and ominous sign. By this stage, tissue oxygen debt is severe and organ injury may be irreversible. Recognition of poor perfusion, manifested by cool extremities, delayed capillary refill, metabolic acidosis, or reduced urine output, must trigger intervention before hypotension develops. Early recognition is critical, as neonatal shock carries high risk for rapid decompensation and multi-organ injury when not addressed promptly. Cardiac output in neonates is defined as the volume of blood pumped per minute, calculated as stroke volume multiplied by heart rate. The normal output is approximately 200 milliliters per kilogram per minute. Because neonatal ventricles are relatively non-compliant and have limited ability to increase stroke volume, heart rate becomes the primary mechanism to adjust cardiac output. Stroke volume, usually about 1.5 milliliters per kilogram, is influenced by preload, contractility, and afterload. Even modest changes in filling or resistance can affect overall performance. Blood pressure is determined by the interaction of cardiac output with peripheral vascular resistance. Systolic pressure reflects peak ejection force, diastolic pressure is the lowest value before contraction, and pulse pressure is the difference between the two. In neonatal practice, a widened pulse pressure often points to a patent ductus arteriosus, while a narrowed pulse pressure may signal pericardial tamponade or severe hypovolemia. These parameters are not abstract numbers. They guide recognition of circulatory adequacy at the bedside and signal when early intervention is required. Stroke volume in neonates is determined by preload, afterload, and contractility. Preload reflects ventricular filling pressure, and because the neonatal ventricle is stiff and non-compliant, small shifts in circulating volume can cause significant changes in output. Afterload represents the resistance the ventricle must overcome to eject blood. An elevated systemic vascular resistance increases wall stress and impedes ejection, while modest reduction in resistance reduces myocardial workload and can improve forward flow. Contractility, or inotropy, describes the intrinsic performance of the myocardium. It can be augmented by catecholamines, which increase intracellular calcium availability through adrenergic receptor stimulation. Calcium itself strengthens contraction by facilitating actin-myosin crossbridge cycling. Digitalis works by inhibiting the sodium-potassium ATPase, which indirectly raises intracellular calcium and enhances contractile force. Conversely, several common neonatal conditions impair contractility. Acidosis decreases the sensitivity of contractile proteins to calcium. Hypoxia reduces ATP generation and weakens cross-bridge cycling. Hypoglycemia deprives the myocardium of substrate for aerobic metabolism, limiting energy availability. Sepsis depresses myocardial function through inflammatory mediators and altered calcium handling. At the bedside, careful assessment of these determinants allows targeted interventions, such as optimizing intravascular volume, using vasoactive agents, and correcting metabolic disturbances to support cardiac output and maintain perfusion. Compensated and uncompensated shock represent two phases of the same pathophysiologic process, differentiated by the ability of compensatory mechanisms to preserve systemic blood pressure. In compensated shock, the infant maintains blood pressure despite impaired perfusion. Tachycardia is prominent as the heart rate rises to preserve output. Peripheral vasoconstriction shunts flow to vital organs, producing cool extremities and prolonged capillary refill. Cerebral perfusion may be only modestly reduced, so mental status changes are subtle, often limited to irritability or lethargy. Renal perfusion falls early, leading to oliguria. Anaerobic metabolism begins, reflected in mild metabolic acidosis. Uncompensated or decompensated shock occurs when these mechanisms fail. Hypotension develops, a late and ominous sign in neonates. Severe tachycardia may persist, but progression to bradycardia is particularly dangerous and often precedes arrest. Peripheral pulses become weak or absent, and capillary refill is markedly delayed, often accompanied by mottling. Mental status deteriorates to stupor or coma, and acidosis becomes profound due to inadequate oxygen delivery and rising lactate. This distinction underscores the need for early recognition of compensated shock. Waiting for hypotension means the infant is already critically unstable and at imminent risk of collapse. Compensatory mechanisms in neonatal shock are designed to preserve perfusion when circulation is threatened. Sympathetic nervous system activation produces tachycardia and peripheral vasoconstriction, helping sustain cardiac output and redistribute blood flow to vital organs. The kidneys respond by conserving sodium and water through activation of the renin-angiotensin-aldosterone system, aiming to restore intravascular volume. Respiratory compensation manifests as tachypnea, an attempt to lower carbon dioxide and counteract the metabolic acidosis that develops from tissue hypoxia. At the cellular level, oxygen deficiency forces a shift to anaerobic metabolism, generating lactate and worsening acidosis. Together, these mechanisms can maintain blood pressure in the early stages, masking the severity of shock. This is why relying on blood pressure alone is unsafe in neonates. Recognition of subtle clinical signs of poor perfusion is essential for timely intervention before decompensation occurs. Uncompensated shock represents failure of the body's compensatory systems. At this point, blood pressure falls because vasoconstriction and tachycardia can no longer sustain cardiac output. This hypotension is a late event in neonates and signals critical decompensation. Severe tachycardia may still be present, but if the myocardium is exhausted, bradycardia emerges. This is especially concerning because it reflects loss of sympathetic drive and is often a pre-arrest finding. Signs of poor perfusion are pronounced. Peripheral vasoconstriction and low output combine to produce cold, mottled extremities, absent or thready pulses, and capillary refill so prolonged that it may be immeasurable. The underlying reason is that systemic vascular resistance can no longer redirect blood to vital tissues, leaving all organs underperfused. Cerebral blood flow is critically reduced, leading to major alterations in mental status, from confusion to stupor or coma. The kidneys, highly sensitive to perfusion pressure, cease urine production altogether, resulting in anuria. Finally, severe metabolic acidosis develops because anaerobic metabolism is the only available energy pathway. Lactate accumulates rapidly, worsening myocardial function and perpetuating the downward spiral. The clinical significance of compensation in pediatric shock lies in how deceptive the vital signs can appear. Blood pressure is often maintained until very late in the course, because sympathetic activation and other mechanisms mask circulatory failure. For this reason, waiting for hypotension as a diagnostic marker is unsafe. When hypotension finally develops, it indicates that compensatory mechanisms have failed and cardiovascular collapse is imminent. At that point, organ injury is advanced, and resuscitation is much less effective. The key is to recognize compensated shock early when subtle signs such as tachycardia, prolonged capillary refill, cool extremities, or reduced urine output first appear. These markers reflect inadequate perfusion even though systemic pressure remains normal. Intervening aggressively at this stage through volume resuscitation, vasoactive support, or treatment of the underlying cause offers the best chance to reverse shock before it progresses to decompensation. The guiding principle is that clinicians must not rely on blood pressure alone. Early recognition of compensated shock saves lives. Shock in neonates is classified by the primary disturbance that limits effective perfusion. Hypovolemic shock results from loss of circulating intravascular volume. Preload falls, cardiac output declines, and tissue perfusion is compromised. Typical causes include acute blood loss from placental abruption, fetal-maternal hemorrhage, or twin-to-twin transfusion, as well as significant fluid shifts or dehydration. Cardiogenic shock arises when the heart itself fails to generate sufficient output despite adequate volume. Ventricular dysfunction may follow congenital heart disease, myocarditis, arrhythmia, or ischemia. Because the neonatal myocardium has limited contractile reserve, it cannot augment stroke volume under stress, leading to reduced systemic perfusion. Distributive shock is characterized by inappropriate vasodilation and maldistribution of blood flow. Sepsis is the most frequent neonatal cause, where inflammatory mediators lower systemic vascular resistance and create maldistributed flow, so blood bypasses critical organs despite apparently normal or even high cardiac output early on. Obstructive shock results when mechanical factors impede cardiac filling or ejection. In neonates, this can occur with tension pneumothorax, cardiac tamponade, or critical outflow obstruction such as severe pulmonary hypertension. The heart may be structurally normal, but output falls because venous return or forward flow is physically restricted. The critical teaching point is that while bedside presentation may overlap, management must be tailored to the underlying physiology. Volume resuscitation is central in hypovolemia, inotropes and afterload modulation are prioritized in cardiogenic states. Vasopressors are essential in distributive shock, and immediate relief of the obstruction, such as chest decompression or pericardiocentesis, is life-saving in obstructive shock. Hypovolemic shock in neonates represents a state of inadequate circulating volume due to loss of intravascular fluid. It is the most common form of shock in this age group, and because neonatal physiology is preload dependent, even modest reductions in circulating volume can precipitate significant compromise. Cardiac output in infants is highly sensitive to preload, so a fall in volume quickly leads to reduced stroke volume and impaired systemic oxygen delivery. The causes reflect both shared pediatric mechanisms and neonatal-specific vulnerabilities. Acute blood loss can occur with birth trauma, surgical procedures, or gastrointestinal and intracranial hemorrhage. Fluid losses arise from vomiting, diarrhea, high-output ostomies, or continuous gastric suction. Third spacing is especially relevant in necrotizing enterocolitis, sepsis, or hydrops fetalis, where plasma volume shifts into interstitial or serous spaces. Preterm infants have the additional burden of significant insensible water loss across immature skin or from open abdominal and neural tube defects, making them uniquely susceptible. Finally, inadequate intake, whether from poor feeding or dehydration, compounds these risks in a population with very limited physiologic reserve. Recognizing these neonatal-specific mechanisms is critical. Because these infants depend on volume to maintain perfusion, early identification and timely replacement of losses remain the cornerstone of management. In hypovolemic shock, the fundamental problem is reduced venous return to the heart. With less circulating blood volume, preload falls, leading to a drop in stroke volume and cardiac output. The neonatal cardiovascular system is particularly sensitive to these changes because ventricular compliance is limited and cardiac output depends heavily on adequate filling. The body activates compensatory mechanisms to preserve perfusion. Tachycardia is the earliest and most reliable response, as the heart attempts to maintain output by increasing rate. Peripheral vasoconstriction redistributes blood flow toward vital organs, though at the cost of cool extremities and delayed capillary refill. Catecholamine release enhances myocardial contractility, providing temporary support for output despite reduced filling. The kidneys conserve sodium and water through activation of the renin-angiotensin-aldosterone system, helping restore intravascular volume but at a slower pace. These mechanisms can mask the severity of hypovolemia, maintaining blood pressure until late in the process. Once compensatory capacity is exceeded, cardiac output falls precipitously, and hypotension develops as a pre-terminal sign. Early hypovolemic shock, also referred to as the compensated stage, is defined by preserved blood pressure despite inadequate perfusion. Neonates and children can maintain systemic pressure through vigorous compensatory responses, which makes early recognition essential. Tachycardia is the most consistent early sign as the heart rate rises to preserve cardiac output. Peripheral vasoconstriction produces cool extremities and delayed capillary refill beyond 2 seconds. Reduced renal perfusion leads to decreased urine output, often one of the first measurable indicators at the bedside. Cerebral hypoperfusion may manifest as irritability or progressive lethargy. Importantly, systolic pressure remains within the expected range, which can create a false sense of stability if other signs are overlooked. At this stage, detection relies on careful attention to subtle clinical cues rather than blood pressure alone. Prompt recognition and correction of volume loss are critical to prevent progression to decompensated shock when hypotension appears and organ injury accelerates. Late hypovolemic shock, also called the uncompensated stage, occurs when compensatory mechanisms can no longer sustain circulation. By this point, intravascular volume is critically depleted and tissue perfusion is severely compromised. Hypotension, which is a late finding in children, signals decompensation and impending cardiovascular collapse. Heart rate may remain markedly elevated, but progression to bradycardia is particularly ominous and often precedes arrest. Peripheral findings include mottled, cold extremities and weak, thready pulses as vasoconstriction fails to preserve flow. Renal perfusion is severely reduced, resulting in oliguria or complete anuria. Cerebral hypoperfusion manifests as altered consciousness, ranging from confusion to unresponsiveness. Recognition of this stage is a red flag for immediate intervention. Aggressive volume resuscitation, rapid identification of the underlying cause, and escalation of support are required to restore circulation. Without prompt reversal, irreversible organ injury and death quickly follow. Management of hypovolemic shock begins with establishing rapid intravenous or intraosseous access to restore intravascular volume. The first-line intervention is fluid resuscitation with isotonic crystalloids such as normal saline or lactated Ringer's solution. Boluses are given at 20 milliliters per kilogram and may be repeated as needed, guided by clinical response. If the cause is ongoing hemorrhage, early administration of blood products is essential to restore oxygen carrying capacity and circulating volume simultaneously. Alongside resuscitation, addressing the underlying cause is critical. This includes surgical control of bleeding, replacement of gastrointestinal or ostomy losses, or treatment of infection and inflammatory processes driving capillary leak. Continuous monitoring guides the effectiveness of therapy. Vital signs, capillary refill, extremity warmth, and urine output provide immediate feedback on perfusion. Mental status assessment is equally important, as cerebral perfusion is among the most sensitive indicators of adequate resuscitation. Early recognition and timely correction of intravascular losses are the cornerstone of preventing progression to irreversible shock. Cardiogenic shock in neonates is defined as shock resulting from primary heart failure. In this state, cardiac output is inadequate despite adequate or even elevated preload. The underlying problem is intrinsic myocardial dysfunction, so the ventricle cannot generate sufficient stroke volume to meet tissue oxygen demands. Unlike hypovolemic shock, where restoring intravascular volume improves preload and output, additional fluid in cardiogenic shock often worsens pulmonary congestion and impairs oxygenation. This distinction is critical for bedside management. Mortality is high if the condition is not promptly recognized and treated. Causes include congenital heart disease with left ventricular outflow obstruction, severe arrhythmias, myocarditis, or ischemia. Clinically, infants present with poor perfusion, hepatomegaly from venous congestion, tachypnea, and often pulmonary edema. The key concept is that volume loading is harmful in this physiology. Management instead relies on inotropic support to improve contractility, careful afterload reduction to decrease ventricular workload, and correction of arrhythmias or structural lesions when present. Early differentiation from hypovolemic shock is essential, as the therapeutic strategies are fundamentally opposite. In neonates and infants, cardiogenic shock most often arises from structural or acquired conditions that impair myocardial performance. Congenital heart disease is a major contributor. Critical aortic stenosis produces severe left ventricular outflow obstruction, while hypoplastic left heart syndrome leaves the systemic circulation entirely dependent on the right ventricle. Critical coarctation of the aorta can present in the first weeks of life with ductal closure, precipitating acute left ventricular failure. Complex cyanotic lesions, especially those with significant ventricular dysfunction or obstructed outflow, can also result in profound shock. Acquired conditions are equally important. Myocarditis causes acute inflammation and weakening of the myocardium. often with rapid deterioration. Cardiomyopathies may be primary or associated with metabolic or genetic disorders, leading to progressive pump failure. Arrhythmias, such as supraventricular tachycardia or complete heart block, compromise filling or effective output, and can quickly trigger shock in the newborn. Inborn errors of metabolism can also manifest with impaired myocardial function due to substrate deficiency or accumulation of toxic intermediates. Recognition of these causes directs management toward prostaglandin infusion to reopen the ductus and ductal dependent lesions, antiarrhythmic therapy when rhythm is the driver, and supportive or disease-specific interventions in myocarditis, cardiomyopathy, and metabolic disease. Secondary causes of cardiogenic shock produce pump failure by mechanically obstructing cardiac filling or ejection rather than by intrinsic myocardial disease. Cardiac tamponade occurs when pericardial fluid accumulation raises intrapericardial pressure, limiting ventricular filling and leading to rapid decline in stroke volume. Clinical hallmarks include muffled heart sounds, poor pulses, hepatomegaly, and circulatory collapse if not relieved by pericardiocentesis. Tension pneumothorax increases intrathoracic pressure, compressing the heart and great veins. This markedly reduces venous return, mimicking severe right-sided heart failure. Prompt decompression with needle thoracostomy or chest tube placement restores hemodynamics. Massive pulmonary embolism, though rare in neonates, can obstruct right ventricular outflow and abruptly elevate afterload, leading to acute right heart failure. When present, it causes sudden hypoxemia, shock, and requires emergent intervention. These conditions share the feature of requiring immediate recognition and reversal of the mechanical barrier to circulation. Delay in intervention results in rapid deterioration and high mortality, underscoring the need for vigilance at the bedside. Cardiogenic shock is driven by primary pump failure, where the ventricle cannot generate enough force to maintain cardiac output despite adequate preload. As forward flow falls, tissue perfusion and oxygen delivery decline. The body mounts compensatory responses similar to those seen in hypovolemic shock, tachycardia, peripheral vasoconstriction, and catecholamine release. However, because the underlying problem is contractile dysfunction, these mechanisms offer only limited benefit and increase myocardial oxygen demand. Unlike hypovolemia, giving additional volume does not restore circulation. Instead, elevated filling pressures distend the ventricles, worsen pulmonary venous congestion, and can produce pulmonary edema or systemic venous congestion with hepatomegaly and ascites. The combination of low output and high filling pressures defines the pathophysiology. Recognition that cardiogenic shock behaves differently from volume depletion is critical. Management requires improving contractility, reducing afterload, and supporting oxygen delivery, rather than aggressive volume resuscitation, which risks further decompensation. The clinical picture of cardiogenic shock reflects both inadequate forward flow and the effects of congestion. Poor systemic perfusion presents as cool extremities, weak or thready pulses, prolonged capillary refill, and altered mental status as cerebral blood flow declines. Because filling pressures are elevated, signs of congestion are prominent. Hepatomegaly reflects systemic venous congestion, while peripheral edema and pulmonary rales point to fluid accumulation in the interstitial and alveolar spaces. Respiratory distress and tachypnea often result more from pulmonary edema than from primary lung disease. On cardiac examination, a gallop rhythm is frequently heard reflecting ventricular dysfunction and elevated filling pressures. Chest radiography typically demonstrates cardiomegaly and may also reveal pulmonary venous congestion or frank edema. Recognizing this combination of poor perfusion with volume overload distinguishes cardiogenic shock from other forms and directs management toward inotropes and afterload reduction rather than aggressive fluid administration. The hemodynamic profile of cardiogenic shock is characterized by reduced cardiac output due to primary pump failure. Ventricular dysfunction leads to inadequate forward flow, which is evident as diminished systemic perfusion and low oxygen delivery. Because the ventricle cannot eject efficiently, filling pressures are elevated. Central venous pressure and pulmonary capillary wedge pressure both rise, contributing to systemic venous congestion and pulmonary edema. This contrasts with hypovolemic states, where filling pressures are low. Systemic vascular resistance may be normal or increased as part of the compensatory vasoconstrictive response. In some neonates, however, systemic resistance may fall if sepsis or acidosis coexist, further complicating management. Mixed venous oxygen saturation is typically low. This reflects both reduced delivery from low output and increased extraction by tissues attempting to meet metabolic demands. Bedside recognition of this profile helps differentiate cardiogenic shock from other types and guides therapy toward inotropic support and afterload modulation rather than volume expansion. Management of cardiogenic shock in neonates centers on improving contractility and reducing the workload of the failing ventricle, while avoiding interventions that worsen congestion. Unlike hypovolemic shock, aggressive fluid administration is contraindicated, as it elevates filling pressures and exacerbates pulmonary and systemic edema. Inotropic agents are the cornerstone of therapy. Dopamine, typically dosed at 5 to 20 micrograms per kilogram per minute, augments both heart rate and contractility. Dobutamine, at 2.5 to 20 micrograms per kilogram per minute, is particularly useful for enhancing contractility and reducing afterload through vasodilation. Epinephrine, at 0.05 to 2 micrograms per kilogram per minute, provides potent inotropy and vasoconstriction, reserved for severe cases requiring escalation. Afterload reduction further supports forward flow. Angiotensin-converting enzyme inhibitors and agents such as milrinone lower systemic resistance, thereby decreasing ventricular wall stress. When congestion is evident, judicious use of diuretics can reduce pulmonary and systemic volume overload without compromising preload excessively. In refractory cases, mechanical circulatory support becomes life-saving. Extracorporeal membrane oxygenation provides a bridge to recovery or definitive intervention when pharmacologic therapy fails. Distributive shock in neonates is defined by inappropriate vasodilation and maldistribution of blood flow, leading to impaired tissue perfusion despite normal or even elevated cardiac output in the early phase. The key physiologic abnormality is a fall in systemic vascular resistance, which lowers perfusion pressure and limits oxygen delivery to vital organs. Unlike hypovolemic shock, where preload is inadequate, or cardiogenic shock, where pump failure dominates, the problem here is that blood flow cannot be effectively directed to critical tissues. Septic shock is by far the most common distributive process in the NICU. Neonates mount an exaggerated inflammatory response to infection, releasing cytokines and nitric oxide that drive vasodilation, increased vascular permeability, and myocardial depression over time. The fragile neonatal capillary network and immature innate immunity make preterm infants particularly susceptible. Anaphylaxis is less frequent but clinically significant, typically triggered by blood product transfusion, antibiotic exposure, or maternal medication transfer. Histamine and other mediators cause systemic vasodilation, capillary leak, and often respiratory compromise due to bronchospasm. Neurogenic shock, though rare in this population, may occur with birth-related cervical spinal cord injury. Loss of sympathetic tone below the lesion produces profound hypotension and bradycardia, distinct from the tachycardia that usually accompanies other forms of shock. Drug-induced distributive states can be seen in neonates exposed to opioids, high-dose anesthetics, or magnesium sulfate, all of which blunt vascular tone and autonomic responses. Another important contributor in critically ill infants is adrenal insufficiency, either due to congenital adrenal hyperplasia or acquired relative adrenal insufficiency in sepsis, which removes cortisol's permissive effect on vascular tone and amplifies shock physiology. At the bedside, distributive shock should be suspected when an infant remains hypotensive with warm extremities, bounding or variable pulses, wide pulse pressure, and poor end organ perfusion despite adequate intravascular volume. Recognition is vital because management differs from purely volume-responsive states. Therapy emphasizes vasopressors such as dopamine, norepinephrine, or epinephrine, coupled with targeted treatment of the underlying trigger, antibiotics for sepsis, epinephrine for anaphylaxis, corticosteroids for adrenal insufficiency. Excessive fluid resuscitation can worsen pulmonary edema and compromise oxygenation, particularly in preterm infants with fragile lungs. The unifying concept is that despite apparently sufficient cardiac output, perfusion fails at the tissue level. Timely recognition and early escalation to vasoactive support are essential to prevent progression to multi-organ dysfunction in the neonatal population. Septic shock is the most important and most frequent subtype of distributive shock in neonates and children. It begins as a systemic inflammatory response to infection, with release of cytokines and mediators that disrupt vascular tone and endothelial integrity. The result is widespread vasodilation, which lowers systemic vascular resistance and creates a distributive shock state. Capillary leak compounds the problem by shifting plasma volume into the interstitial space, adding a hypovolemic component. At the same time, inflammatory mediators and circulating toxins can directly depress myocardial contractility, producing a cardiogenic element. The combined effect is reduced effective circulating volume, impaired forward flow, and maldistribution of perfusion. Sepsis also triggers activation of the coagulation cascade, leading to microvascular thrombosis, consumption of clotting factors, and in severe cases, disseminated intravascular coagulation. As these processes evolve, multiple organs become dysfunctional due to both inadequate perfusion and direct cellular injury. This multifactorial pathophysiology explains why septic shock is complex to manage and why it carries such high morbidity and mortality in the neonatal and pediatric population. In the warm phase of septic shock, inappropriate vasodilation lowers systemic vascular resistance. The vascular bed opens widely, causing blood to pool peripherally rather than being directed to vital organs. This produces flushed skin, bounding pulses, wide pulse pressure, and brisk capillary refill, all signs that flow is maldistributed, not deficient. As compensation fails, cold shock develops. The neonatal heart has limited ability to increase stroke volume, so cardiac output falls rapidly. Vasoconstriction becomes the dominant response in an attempt to preserve central perfusion. Clinically, this results in cool extremities, narrowed pulse pressure, weak or thready pulses, and delayed capillary refill. Temperature instability is one of the earliest systemic signs. Neonates rarely mount a fever. Hypothermia is more common because the immature immune system does not generate a strong pyrogenic response, and limited thermoregulatory capacity makes even small losses critical. Neurologic changes are subtle but significant. Poor feeding, lethargy, irritability, or hypotonia occur because the brain receives inadequate oxygen delivery, and metabolic derangements impair neuronal function. Perfusion abnormalities, such as mottling and discrepancies between central and peripheral circulation, reflect uneven blood flow and early tissue hypoxia. Renal hypoperfusion leads to oliguria. Unlike the physiologic low urine output of the first 24 hours, persistent decline in urine output indicates sustained inadequate renal blood flow and is often an early marker of systemic compromise. Finally, metabolic acidosis and rising lactate represent the biochemical signature of impaired oxygen delivery. Cells shift to anaerobic metabolism, producing lactic acid, and this laboratory finding often precedes hypotension, which is a late and ominous sign in neonates. Management of septic shock in neonates and children depends on early recognition and rapid intervention. Progression to cardiovascular collapse is common if treatment is delayed. The first priority is aggressive fluid resuscitation. Isotonic crystalloid boluses of 20 milliliters per kilogram are given, and cumulative volumes may exceed 60 milliliters per kilogram depending on response. Careful titration is necessary to avoid fluid overload. Antibiotics should be administered within the first hour, since delays increase mortality. If fluids alone are inadequate, vasoactive support is indicated. Dopamine is often used as an initial agent in pediatrics. Epinephrine is recommended when shock persists despite dopamine, and norepinephrine is most effective in warm shock characterized by severe vasodilation and low systemic resistance. Corticosteroids may be added in catecholamine-resistant shock, particularly when adrenal insufficiency is suspected. Source control is equally important. Drainage of abscesses, removal of infected catheters, or surgical procedures to eliminate the nidus of infection must accompany hemodynamic management. Throughout care, close monitoring of vital signs, Urine output, mental status, and laboratory indicators of acidosis guides therapy and helps prevent multi-organ failure. Assessment of shock at the bedside depends on systematic evaluation of multiple parameters rather than any single vital sign. Vital signs provide the foundation. Blood pressure should be measured in all 4 extremities, as discrepancies may reveal obstructive lesions such as coarctation or interrupted aortic arch. Heart rate and respiratory rate must be interpreted in the context of perfusion. Perfusion assessment is crucial. Capillary refill time reflects microcirculatory flow, while skin temperature and color indicate the degree of peripheral vasoconstriction. A cool, pale, or mottled appearance is a sensitive sign of early compromise. Pulse quality gives further insight into hemodynamics. Weak, thready pulses are consistent with low stroke volume or poor output, while bounding pulses may suggest a pathologic runoff lesion, such as patent ductus arteriosus. Neurologic status must also be monitored. Irritability, lethargy, or reduced responsiveness signal impaired cerebral perfusion and are often earlier indicators than hypotension. Urine output is an essential end organ marker. The goal is greater than 1 milliliter per kilogram per hour, as reduced output reliably reflects falling renal blood flow. Together, these physical findings provide a more sensitive and earlier diagnosis of shock than blood pressure alone. Laboratory studies complement the physical exam by identifying metabolic changes and uncovering underlying causes of shock. Blood gas analysis is one of the most informative tools. Low pH, elevated lactate, and a rising base deficit indicate tissue hypoxia and anaerobic metabolism. These findings reflect the adequacy of resuscitation and help guide therapy. A complete blood count provides several critical insights. Hemoglobin concentration identifies anemia as a contributor to poor oxygen delivery. White cell count may suggest infection or inflammation, and platelet levels provide early warning of consumptive coagulopathy. The comprehensive metabolic panel evaluates electrolytes and renal function. Abnormal sodium or potassium levels may worsen arrhythmias or contractility problems, while rising creatinine or blood urea nitrogen indicates reduced renal perfusion. Liver function tests add another dimension, as elevated transaminases can reflect hepatic hypoperfusion or shock liver. Coagulation studies assess for disseminated intravascular coagulation, a common complication of sepsis and severe shock states. When infection is suspected, blood cultures are essential. Identifying the causative organism allows targeted antimicrobial therapy, which is critical for reversing septic shock. Laboratory data, when interpreted alongside clinical findings, not only confirm the presence of shock, but also highlight contributing factors and guide both immediate and definitive management. Advanced hemodynamic monitoring provides detailed insight into the cardiovascular status of neonates and children in shock, guiding precise interventions beyond what physical exam alone can reveal. Central venous pressure reflects ventricular preload. Elevated or low values help distinguish between volume overload and depletion, informing fluid resuscitation decisions. Arterial lines enable continuous, beat-to-beat blood pressure monitoring, which is essential for early detection of hypotension and evaluation of response to therapy. Pulse contour analysis offers dynamic information on stroke volume variation, indicating whether cardiac output is likely to improve with additional fluids or requires inotropic support. Echocardiography allows direct assessment of cardiac function, including ventricular contractility, chamber filling, and valvular competence, providing real-time guidance for tailored management. Mixed venous oxygen saturation measures the balance between oxygen delivery and consumption. Low values signal inadequate tissue oxygenation despite apparently normal systemic blood pressure, emphasizing the need for optimization of cardiac output and oxygen delivery. Integration of these modalities enhances the clinician's ability to detect early decompensation, distinguish shock subtypes, and titrate therapy appropriately, ultimately improving outcomes in critically ill neonates. Hemodynamic management in neonatal and pediatric shock is guided by clear, measurable goals that indicate adequate tissue perfusion and oxygen delivery. Maintaining age-appropriate blood pressure is essential to ensure sufficient perfusion of vital organs, but blood pressure alone is not a reliable early marker of shock in children. Clinical assessment of perfusion is equally important. Warm extremities and brisk capillary refill reflect effective microcirculatory flow, while normal mental status indicates adequate cerebral perfusion. Renal output serves as a sensitive end organ marker. A urine output greater than 1 milliliter per kilogram per hour demonstrates that kidney perfusion is preserved. Metabolic markers provide additional confirmation. Normalization of lactate and base deficit indicates that oxygen delivery meets tissue metabolic demands, and that anaerobic metabolism has been corrected. Achieving these hemodynamic targets requires ongoing evaluation and adjustment of fluids, vasoactive medications, and supportive therapies. Continuous assessment ensures early recognition of deterioration and prevents progression to uncompensated shock. Dopamine is often chosen as a first-line agent in both distributive and cardiogenic shock because of its mixed effects. At doses of 5 to 10 micrograms per kilogram per minute, the inotropic action predominates, increasing cardiac output. When the dose rises above 10 micrograms per kilogram per minute, alpha-adrenergic stimulation leads to vasoconstriction and an increase in systemic vascular resistance. Neonates clear dopamine unpredictably, particularly if renal or hepatic function is impaired, so titration requires close bedside assessment. The maximum infusion rate typically used is 15 micrograms per kilogram per minute. While useful, some studies suggest dopamine may reduce cardiac output when vasoconstrictive effects outweigh inotropy, making careful titration essential. Epinephrine is a powerful inotrope with both beta-adrenergic and alpha-adrenergic effects. At lower infusion rates, beta-1 stimulation predominates, increasing myocardial contractility and heart rate, which raises cardiac output. At higher rates, alpha-1 effects add systemic vasoconstriction, elevating systemic vascular resistance. It is frequently selected as a second-line drug for distributive shock unresponsive to dopamine, or as a first-line choice in severe cardiogenic shock. Infusions typically begin at 0.05 micrograms per kilogram per minute and are increased in small increments, with a maximum around 1 microgram per kilogram per minute. Norepinephrine acts mainly as a vasoconstrictor. Its alpha-adrenergic effect raises systemic vascular resistance and increases arterial blood pressure, with less effect on heart rate than epinephrine. It is often used in older children and adults with septic shock, but neonatal data are more limited. Dosing usually starts at 0.05 to 0.1 micrograms per kilogram per minute, titrated upward as needed, with some reports of safe use up to 2 micrograms per kilogram per minute. In neonates with fluid refractory septic shock, norepinephrine may restore perfusion when dopamine or epinephrine are inadequate. Dobutamine is primarily a beta-1 agonist that increases myocardial contractility and improves cardiac output. Its impact on systemic blood pressure is variable. In some infants it rises, in others it falls, depending on the balance between improved output and vasodilation. Because of its strong inotropic effect, it is considered an appropriate first-line medication for cardiogenic shock. Neonatal clearance of dobutamine is variable, so response must be carefully monitored. Infusion typically begins at 5 micrograms per kilogram per minute, and can be titrated up to 20 micrograms per kilogram per minute. Milrinone is a phosphodiesterase type 3 inhibitor with dual actions. It enhances contractility by increasing intracellular calcium and produces systemic and pulmonary vasodilation. This combination makes it useful for low cardiac output states after congenital heart surgery and for infants with pulmonary hypertension. Its role in undifferentiated neonatal shock is limited and should be guided by cardiology consultation and echocardiographic evaluation. Hypotension is a common complication, and neonatal dosing data are sparse, making careful monitoring essential. Vasopressin is an endogenous antidiuretic hormone analog that increases systemic vascular resistance through V1 receptor stimulation. Unlike catecholamines, it redistributes blood flow to vital organs such as the brain, heart, and lungs. In neonates, it is primarily used as rescue therapy in septic shock that is resistant to dopamine and epinephrine. Evidence in preterm infants is limited, and risks include hyponatremia and ischemic complications from intense vasoconstriction. Because of these concerns, vasopressin is generally reserved for refractory cases and used under specialist oversight. Key clinical pearls summarize critical principles for recognition and management of pediatric shock. Hypovolemic shock is the most common type and typically responds well to careful fluid resuscitation, reflecting its preload-dependent physiology. Cardiogenic shock requires a different approach, as excessive fluids worsen ventricular congestion. Inotropes and afterload reduction support contractility and forward flow. Septic shock combines distributive, hypovolemic, and cardiogenic components. Rapid administration of antibiotics within the first hour and aggressive fluid resuscitation are central to reversing the pathophysiology. Compensated shock highlights the limitations of blood pressure as a sole marker. Normal systemic pressure does not exclude impaired perfusion or early shock. Early recognition across all shock types is critical to prevent progression to cardiovascular collapse. Management must be tailored to the underlying pathophysiology, as hypovolemic, cardiogenic, and distributive forms each require distinct interventions. Adherence to these principles improves organ perfusion, prevents irreversible injury, and optimizes outcomes in critically ill neonates. Neonatal shock occurs when tissue oxygen delivery is insufficient for metabolic demands, even if compensatory mechanisms maintain blood pressure temporarily. Hypovolemic shock is the most common type in neonates, arising from blood loss, third spacing, or inadequate intake. It responds to careful crystalloid boluses because neonatal cardiac output is highly dependent on preload. Cardiogenic shock results from primary myocardial dysfunction, such as congenital heart disease, myocarditis, or arrhythmia. Additional fluid can worsen pulmonary congestion and compromise oxygenation, so therapy focuses on inotropes and afterload reduction. Distributive shock is characterized by inappropriate vasodilation and maldistribution of flow. In neonates, sepsis is the leading cause, producing vasoplegia, capillary leak, and sometimes myocardial depression. Compensated shock emphasizes the danger of relying on blood pressure alone, which may appear normal. Early recognition of subtle signs such as tachycardia, delayed capillary refill, cool extremities, oliguria, or altered mental status is essential to prevent progression to decompensated shock. Neonatal shock assessment requires careful physical examination, laboratory evaluation, and advanced hemodynamic monitoring. Vital signs and perfusion parameters provide early indicators of compromised output. Tachycardia, cool extremities, delayed capillary refill, weak pulses, and subtle changes in alertness are often the first clinical clues. Urine output greater than 1 milliliter per kilogram per hour indicates adequate renal perfusion. Laboratory markers, including pH, lactate, base deficit, and electrolytes, quantify tissue hypoperfusion and guide interventions. Advanced monitoring with central venous pressure, arterial lines, echocardiography, and mixed venous oxygen saturation allows real-time evaluation of preload, cardiac function, and tissue oxygen delivery. Management is tailored to the type of shock. Hypovolemic shock is treated with cautious crystalloid resuscitation. Cardiogenic shock requires inotropes and afterload reduction while minimizing fluids, and septic shock combines aggressive fluids, early antibiotics, and vasoactive support. Hemodynamic targets include maintaining age-appropriate blood pressure, warm extremities, normal mental status, adequate urine output, and correction of metabolic acidosis. Recognizing compensated shock early and intervening before hypotension develops is critical in the neonate to prevent cardiovascular collapse and multi-organ injury.